So there's a great deal of interest in CD47 as a target in myeloid malignancies. The first-in-class drug, Magrolimab, has shown very intriguing data in the phase 1 portion and phase 2 portion of the study, showing high response rates, durable responses in patients with myelodysplastic syndrome when Magrolimab is coupled with Azacitidine. And in early looks at the data, at least, there seemed to be a signal for activity in patients with p53 mutated myelodysplastic syndrome. And so, of course, these drugs are being developed further in the myeloid neoplasms, and Magrolimab has moved into phase 3 studies. One of the problems with Magrolimab is Magrolimab actually has an on-target effect of causing anemia early on. And of course, there are mitigating practices to protect patients from that initial anemia with a dose ramp up with Magrolimab. Evorpacept is a different anti-CD47 targeting drug. It's actually a combination or a fusion of a portion of SIRP-alpha, which is the receptor for CD47 on macrophage, with an Fc portion of an antibody that has been constructed not to fix complement, not to attract macrophage. So on its own, we wouldn't expect Evorpacept to actually have activity because the Fc portion of the molecule actually would be inactive. So that's the safety portion of it. There is a ongoing phase 1 study in MDS with Evorpacept and Azacitidine. We are now in the dose optimization portion of that study as well, and is close to completion of accrual. And that's going to help inform the phase 2 dosing also of the Evorpacept trial in AML, which I am leading. And we are presenting, Guillermo Garcia-Manero is presenting our data in a poster at ASH 2022. What I could tell you so far in this very early look at the data, the thing that has intrigued me the most about the combination of Evorpacept with Azacitidine and Venetoclax is that we had patients on this clinical trial who had just been exposed to Azacitidine and Venetoclax and had resistant disease with rising blast counts. And the next treatment they saw was the exact same combination of Aza with Venetoclax with a single dose of Evorpacept on day 1. We have reached the dose that we are going to go forward with at 60 milligrams per kilogram every 4 weeks. In those patients, including one of mine, I saw blast clearance, and we saw blast clearance or blast reductions, showing a biologic effect of adding Evorpacept to Azacitidine Venetoclax in a situation where those two drugs had just been shown to be ineffective. I think that's very exciting data, and probably more important than seeing CRs or CRHs in an early look at the data. Of course, the proof of the pudding will be if this combination leads to CRs with hematologic recovery that are durable.